All right, so some motivation this morning from a patient who, let me say this, he's hanging on the top of the hole, but he's in my mind a little bit close to going down the rabbit hole of lots of cooks in the kitchen, and I'm not doing a good enough job of communicating. That's pretty obvious to me in terms of helping this individual understand the rabbit hole that he's about to go down, particularly now when it's about pathoanatomy. In this case, before coming to see me, he'd already gone through the process of getting a cervical MRI, which does show some pathoanatomical changes. However, here's an individual that has nearly full range of motion after treatment. It does not stick completely, but we are I'm very happy with how it's improving. And played 18 holes of golf a few days ago. This individual is very active. I have tried to insist to him that while we're not denying what that MRI says, and we're not denying the altruism of the people ordering the MRIs and the people reading them and the people that are describing their opinions on what they're seeing and what they might do about it one day, all of those things are real. But this is an unfortunate time when if you hadn't ordered the MRI before you came to see me, and now you're doing this much better, you probably would never have had the MRI because you wouldn't think there was really anything wrong with the neck. So that led me to a little bit of communication on how we try to look at things and how we can, number one, decide how we'll react to the severity of it, how we're going to prioritize what we can do in terms of physical therapy and training, but when we need to refer out, and then to who. Because at the end of the day, I find it appalling. I've mentioned this before. I find it ranging from confusing to disgraceful as to why ordering imaging is so vilified. This is information. No one that I'm aware of at this point has X-ray or magnetic vision. This is information that can help make decisions for therapy, can help make decisions for referrals. It can help understand the cost analysis of, hey, should we try to do something more conservative? Because in this case, when we see these typical things combined with these typical things that we're seeing in your physical exam, man, they don't usually do very well. Maybe if we go down this more reliable path, I don't know. But imaging can help us decide, what is the cost of doing business and how long we could wait, in terms of seeing a result with something conservative or less aggressive like injections. So now in this case, I'm falling victim what I think a lot of people are concerned about. You kind of lose control, and it's not so much. Listen, I get paid, whatever. I mean, you do the best you can, and if the patient is not the right fit for the type of therapy that you want to provide, well then, it's 4th and 10. Hit the skids, bud. So I'm not that. It's not like the control is required for anything more than that. But at the end of the day, if you really want to help somebody, and you think you can, in this case, I'm not seeing anything that this individual has that requires significant, even referral outside of physical therapy. I'm not sure I would even have ordered imaging on anything. But it's a tough spot. I think we can do a pretty good job with this individual of talking him off the ledge a little bit. And how we did that this morning was talk about, number one, if I felt that there was some kind of significant issue, I am legally bound to refer you and not even treat you. Okay, so when these people are saying you're gonna die unless you have a cervical fusion, that wasn't the message, but it's pretty gosh darn close. Then I don't see that. So either I'm breaking the law and showing significant negligence by treating you that requires this fairly serious intervention, it's just, I don't see it. It's not there. And here are the reasons why. You can do this, you can do this, you can do this. And the logic is that if you could do all those things, you would never have gotten the MRI, meaning a lot of people can have these pathoanatomical changes and not be aware of them because there's nothing wrong, so they don't get an image, so they're unaware that they have those types of changes. So that's the story with the imaging and how we got here. So here's what we talked about. I said, like, to the patient, like, I try to look at things along with my legal responsibility to refer people out and discontinue treatment. I'm looking at I've said this before, I don't say it that often, the topics just haven't come up. When I am looking at, for an evaluation, one of the primary core values of the Keen movement evaluation is to find out that I am not the right person to help. Okay, I'm trying to refer out to other people, to other specialties, because if my evaluation tells me that my skill set can't help, or my skill set only has a very limited risk reward without these others in conjunction, that's a significant goal. Meaning, if it sounds like what I'm saying, Charlie, you're trying to evaluate so you can't help the person. No, it's not that I can't help the person, it's that I'm not going to do the work. And I know there's not a lot of people that think like that, and that doesn't make me better than them. It's just an interesting vlog here on Instagram, soon to be on SafeSpot. But so once he understands that. He understands, like, what I'm trying to do is try to decide that I am not the best person to work for you. You might be asking the question, well, how do you make any money on that? I'm like, yeah, ain't my problem. So because I'd like you all to get to a certain place where your clinical approach, you're able to charge so much money so that you can feel great and feel easy about referring people out, etc. So that because you're making in one session what maybe some in-network joker is making in a month. So you have the ability to do that, and people remember. They remember, even if you never see them again for a long time, and they come back and pop their head in and be like, "Hey, I just want to thank you. Yeah, I wound up getting that cervical fusion, but it was because you insisted that I did, and instead of taking my money." So with that in mind, I'm going to try to look for, when we have painful patterns, we're going to categorize them in 3 different ways. I'm going to make up my own words here. The words aren't made up, but the definitions might be. So if you're going to use other words, then you're right, okay? My words are not the only. I'm very critical of clowns that make up their own words and their own little 3 letters that are completely exclusive, and the only way to learn it has to be that way, so you got to take their courses. Now, you can use any words you want, but I want you to look at pain, musculoskeletal, what appears to be musculoskeletal pain. I want you to look at it in 3 different ways, and the first one is medical. So we should know that there's a map, a catalog of musculoskeletal pain that is being generated by the viscera or organs. And that's a medical problem. That's a medical emergency in a lot of different cases, where there could be pain that clearly looks like and smells like and feels like something that has a more prime musculoskeletal origin, but it's an organ. It's an organ that's generating that, and that's an immediate referral. So there's a map. You kind of have to have it memorized, just like other things that we have to have memorized. It's a good, some of the other things you might angle towards is that typically it's on one side but not the other. Typically these types of organically or medically generated musculoskeletal symptoms they're not provoked or improved by movement. So because it's not this bone, nerve, it's of course a nerve if you're expressing pain, but it's not a bone or a muscle or a fascia, etc. That's generating this threat. It's an organ that is generating this threat. So I think we need to be clear on when that. Now, I use this to explain it because, hey, if I saw this, I would refer you out, even though there is no consistent, what I call a medical pattern or a medical origin of this individual's neck pain or concomitant stuff throughout the shoulder and elbow. So that's number one. Hey, something else as it relates to that, while I got a little bass in my voice, this is a good reason why we should feel very comfortable in drawing a soft dotted line in terms of evaluating for what pain is, and that we're working with the proper professional. I'm not even going to say healthcare professional, because information is not exclusive to where you went to school. However, typically where we go to school gives us the experience and repetitions in seeing things. I don't think a non-healthcare provider is not smart enough. I don't think that they're unaware, they could read, etc. But when you don't see these things, because you're primarily not seeing people in pain, it's not front of mind and you miss things. So I'm not saying you don't train while you have pain if it's in the other categories that we'll discuss. But man, like, you know, not only is there I think far too often a lack of respect to the next category, but if we're completely unaware, this person can die. You know, if we're unaware of these differential diagnoses that I'm saying fall into the medical origin. If you don't have a lot of experience in seeing people that have these things, I've talked about, maybe I'm a little bit more emotional to it for two reasons. Number one, the first time I ever saw or was a part of the identification of what I'm calling a medical etiology of musculoskeletal symptoms was when I was a student at Ursinus College, and I believe a young lady was having back pain. I probably said this before, whether it's in presentations or other mediums. It turned into ovarian cancer, and I just remember it. I don't remember the girl's name. I remember she played field hockey, because most of the stud girls at Ursinus College just played field hockey. But I just never forget that. And like, how dare I not refer someone out, or how dare I not know? And then, of course, I had an issue where had a little thing cut out. Maybe that's not a big deal to a lot of people that are more familiar with some of these pre-cancerous skin conditions, but part of it was because it was after I had my shoulder scoped, and my shoulder wasn't improving, and it wasn't necessarily a pain issue, but when that thing got cut out, all of a sudden my shoulder started to move a little bit. So was there some kind of aberrant tension? Look, it's and then I've seen a couple others, particularly where we refer out, and it has not been a positive thing, but there was good enough reasons to do that. So number one, first category for musculoskeletal symptoms is, can the pain be coming from the viscera or organs? And I think that is a crucial piece. Now, we're not going to see a lot of carryovers into the next two, so it's not a Venn diagram, but I guess it's possible, but not likely, because at the end of the day, these medical issues aren't that likely in the first place. But the second and third are certainly going to be the significant percentage. So I'm going to call the second group of musculoskeletal symptoms orthopedic. Now I got to get fussy with these words, because I'm just trying to describe things in different ways. If orthopedic doesn't click for you, pick a different word, please. Like, no one owns... none of these words are copyrighted where you're going to get in trouble and get a nasty email if you use them, okay? Orthopedic is referring to now something that has been confirmed on imaging in most cases, but something is so torn, is so degenerative, that it doesn't mean that conservative treatment doesn't have a role. It does not mean that the issue that we're seeing at the orthopedic level is even relevant, okay? Because when we get into the next category and they go together, maybe we'll find that the torn meniscus, which I would consider an orthopedic issue, because there is no technique that I am aware of, you either, that can untear a meniscus, unless, of course, you have the time stone, which I think has been destroyed when Thanos hit the snap. So you cannot go back in time and untear a meniscus. You cannot untear a hamstring. Now, we know that these things will heal, but our conservative approaches are simply going to push the healing process. And even then, if the tissue, if we don't have a belief that will heal because imaging describes a particular pattern, we put that into an orthopedic category, and usually that's a kick. That's a kick to a surgeon or perhaps a non-surgical orthopedist that will be able to be keen with their injections and just start to manage things. But these are things that typically physical therapists can't do. During my time at MARSOC, you did have the ability to run imaging and to run injections, et cetera, as a physiotherapist. And I'm sure, under the table, some therapists are doing that because they've got the trust and they have the relationship. So again, the side message to this orthopedic piece, you're not going to untear things, but so there's no endeavor to learn the strategies to unsprain an ankle when the three lateral ankle ligaments are in 6 different pieces. Okay, there's nothing you can do other than let's start to push the healing process and refer out, because that healing process may not get you to a satisfying place. Endeavor to have the relationships with those types of physicians, that they're not going to exact control, they're not going to feed like how I started this video. They're not feeding the patient these crazy ideas of what they would do surgically, which aren't even wrong. They're just completely out of line and adding to significant anxiety and probably, if we actually measured, sympathetic load. Talk therapy can ride your sympathetic nervous system high, and it can ride the parasympathetic system high. They're both very effective. That's why talk therapy works and why you feel better, in my mind, where you can always measure things at these physiological levels. So that second category as orthopedic is that when something is not going to be changed or undone with conservative approach, there's a healing process that has to happen, and if that process is so unsatisfactory, we need to look at other more aggressive procedures. So are we evaluating to get them to the surgeon as quickly as possible? And none of this, well, let's just see how it goes, or you're going to do your magical 3 times a week for 4 weeks and then refer them just so you can squeeze their insurance, or even if you're getting paid legitimately. No, it's one and done. And if you're not charging enough for that to be a viable business approach, well, then you're on a B team. I mean, that person doesn't deserve that type of interaction. They deserve if you think that they should be getting kicked to someone else and you make less money on the deal, that's the right way to do business, in my opinion. And again, a little bass in my voice right there, because it happens. And look, I get it. If you're a sorry in-network therapist in a facility, that's making you see 800 people an hour, it's your only option. You got to keep them in there as long as possible, and it doesn't really matter. And look, that might be a tough message, and it's going to make you real angry. But you're not angry at me. You're angry because of what I'm saying is the truth. Orthopedic issues should absolutely be managed with someone that has more aggressive approaches in terms of injections, in terms of pharmaceuticals, in terms of surgeries. All these things that people vilify, not because they think they're bad. I know they're not that stupid, but ultimately they're probably more afraid of losing their control, losing their ability to exert altruism, and obviously losing some dough, which is, hey, just admit it. It's okay. Like, if you don't admit it, that's when you're pumped. Okay? So now we've got medical. We've got orthopedic. You can pick a different word if you don't like orthopedic. You pick a different word if you don't like medical. Musculoskeletal is not one of the words you're going to pick, because I'm describing musculoskeletal symptoms in these 3 categories. The last one is always what you want to see, which I will term neuromuscular. And that's going to fit all the different patterns that, figuratively put a knee that hurts and take a rubber band and yank it inwards, and all of a sudden when they squat, their knee doesn't hurt anymore. That could not have been primarily a torn meniscus. That could not have been a popliteal artery aneurysm. It had to be this other thing. In that case, if you went to USC, you're gonna describe some mechanical model. If you're from Washington D.C. area, you're gonna describe a rectus femoris trigger point that changed tension, while they squatted because of the band. If you're from Michigan, you're gonna say it was because you mobilized the navicular. All of these things work, and I'm obviously being sarcastic because all of those people probably think that's the only thing that works. But when something fits a neuromuscular model, it can be all these different approaches can become very successful. And because we could probably agree that we all want that knee to feel better when they squat or do something functional where their knee is not happy. Okay, so there could be tons of different constructs that help support the intervention that you choose. But I think now, if there's an endeavor to, and this is what I call more keys on the key ring wins, if you've got quicker, what appear to be more magical, what I don't use that term anymore, as you know, but if you can get a dramatic response, where all you're really doing is modulating the nervous system and retesting the muscular system through movement, then it couldn't have been anything more serious than a perception of threat. Now, that doesn't mean that the orthopedic piece was non-existent. It does mean it's irrelevant at that time. So all of these different constructs of mechanics, regional interdependence from multitude of different levels. Regional interdependence was originally discussed at the time when those clinical prediction rules were very, very famous. I believe, whether they've been proven wrong or not is different than when they're proved wrong in the literature versus your applied practice. That being said, it was really this very joint by joint, which certainly rules the roost in many different approaches in rehab, not all the time, not nearly as much as the training process. This mechanical piece that if this doesn't do well, this neighbor has this issue, and regional interdependence would typically fit into that neuromuscular model. But there's fascial lines, there's different points of in fascial manipulation, there's trigger points. We're trying to evaluate for fascial chains, because I think that even though I think fascia is typically presented as a component unto itself, I think that does probably encapsulate from an evaluation model. If you can figure out the chain, and there's some prefabbed ones depending on who you follow, I try to make up my own based on what we see from a full and complete SFMA, meaning we're looking at the whole body regardless of what the person says, and we're looking for the line, the link. Okay, well, if this, and this, well, then there's my chain of where we'll treat and exercise, and then we'll find the retest, the comparable sign of something that was our original musculoskeletal system. So you definitely will see an overlap between orthopedic and neuromuscular. But if your neuromuscular stuff works, it has to be more of a priority, and it devalues the relevance of the orthopedic piece, even if you don't even have it confirmed. I saw someone that years ago, he was scheduled for a meniscectomy the next day. He was just impressed upon to come in. I don't remember his name. Obviously, I wouldn't tell you if I did, but he was like a big-time voiceover guy in Hollywood, and he did a couple of voices. So that's also why I remember this, even though I don't remember his name. So we treated all from a neuromuscular approach, because remember, I don't have any ability to untear a meniscus, and he did split squats leaving drive. I don't know what happened after he turned right and then another right to hit the elevator. He probably got a meniscectomy down the road, but that day he had no knee symptoms. So maybe he never did. Because we treated other things up and down the chain, typically in his case through the quad, and trying to affect the pelvis, which is, if that's not interregional, it's regional. Interregional would probably be linking everything north. But that's what we tried on day one, because I don't think treating stuff north is always going to affect the knee nearly as much as if we treat close by. Because our goal of that day one is to say, hey, should you get surgery tomorrow? And he did cancel the surgery. That much I remember. I have no idea. And look, he wouldn't tell me, because remember, when things don't go always the way that you storybook write them to go, your patients don't come back and tell you. They don't tell you suck. They don't come back and tell you didn't get it done. And that's another little sidebar from the neuromuscular piece, where sometimes things work quickly, but then they don't come back, and you think, oh man, I fixed them in one shot. No, you didn't fix them. They just never came back to tell you that you suck. And you had a very misguided approach, because they had to go to see someone else, because they actually didn't think you helped them. So definitely not a Venn diagram between medical, orthopedic, and neuromuscular. But when we look at pain, through whatever model you're using. Hopefully it's as complete as possible, where you can find all painful and non-painful contributions to musculoskeletal symptoms. I'm using these words very carefully, but if you, again, I'll say it a million times, if you like different words, use them. My words are no better than yours. They make sense to me, but at least I'm not making them up. Medical, orthopedic, and neuromuscular are all words you've heard before. So I think if we can evaluate that painful segment or that painful contributor into those three categories, we'll get to the lowest hanging fruit and the best solution as quickly as possible, even if you're not the one to be executing that. I'd like to say sometimes, like, I promise you will be 100%, you will do everything you want to do. It's just not going to be me that does it, or it's just not going to be done on the terms that you expected. What do you mean? What do you mean? I need you to see a surgeon. Why should I see a surgeon? Because I think you need surgery in your knee. At the end of the day, should this physical exam that we're doing as a physical therapist, a chiropractor, even as a trainer, would that, like, I don't know the reason as to why that physical exam, that evaluation, would be any different than the evaluation that the surgeon would use. In fact, if anything, it's a better evaluation because it's more complete. You know, a surgeon is not going to necessarily be interested or even capable of addressing issues that those clinical prediction rules or that regional interdependence. You know, don't get mad at them that they did. How come my surgeon didn't tell me that my thoracic spine was a part of their shoulder? Because they're only looking at you to determine if this is an orthopedic issue, or because they are trained and have much more experience than most others if it's a medical issue. Medical, orthopedic, neuromuscular, all painful segments should be categorized in one of those three to get to the best approach to intervention. So hopefully that makes sense. And if you check Instagram, obviously at the time of filming, you're going to notice that I went by a gate last night in Atlanta. And that gate, which was not my gate, it was another gate, but that plane was on its way to Mobile, Alabama. And if you look closely into the Crichton section of Mobile, Alabama, there's a tree. And if you look up in that tree, and if you shine a light, there's often something that disappears, and that something that disappears is a leprechaun. So if anybody's seen a leprechaun, say yeah.